Hi, I'm Andrew Whitfield Cook. At FX Medicine, we strive to be clinically relevant for you. So please get in touch with us if there's a topic you'd like us to explore or a specific expert you'd like us to interview. You can email info@fxmedicine.com.au or contact us via Facebook, Twitter and Instagram. This is FX Medicine. I'm Andrew Whitfield Cook. Joining me on the line today is Elizma Lambert, who graduated in 2002 with a Bachelor of Health Science, Homeopathy, and Advanced Diploma in Naturopathy, which includes nutrition and Western herbal medicine. Elizma is passionate about finding connections between symptoms, biochemistry, environment, diet, and genes. Even as our understanding of chronic disease becomes more complex, the answers remain simple. Disease is not a noun, but a verb. It merely shows that the body and biochemistry has become unbalanced. Elizma divides her time between research, fermenting, making bone broths, keeping active and spending time with her family. She plans to retire when she finds the answer to longevity. You can find out more about Elizma at realizehealth.com.au/Elizma-Lambert. Welcome to FX Medicine, Elizma. How are you?
Oh, very well. Thank you, Andrew.
Now, you've been overseas or are going overseas soon, aren't you, to do some lecturing?
That's correct. Yeah, I have been overseas the last few months, going to the UK, going to the US, and I may be going to Scotland and to the US to teach practitioners about various aspects such as organic acid testing and so forth. So there's been a lot of opportunities opening up this year for me. So yeah, we'll see where the year takes me.
Now today we're going to be talking about quite a complex syndrome. That's chronic inflammatory response syndrome, or CIRS. But I guess before you take me through a definition of what that is, can you take us through your background and how you came to be in natural medicine? What directed you towards natural medicine in the first place?
Well, Andrew, I was brought up in a household in South Africa where my mother used to take us to a homeopath whenever we got sick, which wasn't very often, which is good. But it sort of like gave me a natural gravitation towards natural medicine. And so I studied for about 4 years in South Africa and then another 2 years in Australia to get my qualification in homeopathy and naturopathy. And my children were actually the ones who really perpetuated my development as a practitioner because they both had challenges with language development, ADD, and other symptoms where the medical profession wanted to sort of like throw a label at them. And I just was not interested in labels. I wanted solutions. And so it forced me to do my own research. And at that point, there wasn't really that much available in Australia. And so I had to take my research to the States, where I found a lot of therapies and things that help them. And I guess, the rest is history. Like we've resolved all of the issues. And it sort of like taught me a lot of things which I even today base my practice on that experience. That it doesn't matter what you call a disease or a disorder, that all of it is just biochemical processes that has gone wrong. And if you can identify the challenges, the blocks or the inhibitions in the biochemistry, and you remove these, then everything can just flow as it should, and then you can pretty much treat anything. So it's exactly what you said earlier about a disease being a verb and not a noun. It is a process. It is not an entity on its own. So that's how I treat everything in my practice.
Yeah. Okay, so you've grasped something quite complex, something which eludes me, and that's CIRS. Can you take us through exactly what this is and what it encompasses? Because it's really like a ball of wool to me.
Yeah, it is. It's a big, huge rabbit hole that goes into more rabbit holes. Because CIRS, as you pointed out, stands for Chronic Inflammatory Response Syndrome. And it is a body-wide inflammatory condition and pretty much the chronic version of SIRS, which is systemic inflammatory response syndrome. But it is also commonly known as biotoxin illness or mold toxicity syndrome, even though it can actually be caused by many, many other organisms as well. And so you can divide CIRS into different subtypes as well. You can get CIRS acquired by exposure to water-damaged buildings. You can get CIRS acquired from dinoflagellating algal sources. You can get CIRS acquired from stealth pathogen sources such as Borrelia. But, really you can add a lot of other organisms and toxin sources to that list because it's any organism that can trigger a chronic inflammatory response syndrome that can actually be grouped in here. And the only thing is that it's the mold biotoxin illness in the line that gets all the publicity. So that's why we focus on that. But they are really only just two causes of CIRS. And in fact, mycotoxins only makes up about 1% of the problem. They are finding that a lot of inflammagens, such as endotoxins, beta-glucans, hemolysins, proteinases, mannins, there's just so many compounds, even, your volatile organic compounds, they can all play a much larger role in developing CIRS, but they are just much harder to see. And so CIRS is really an immune system reacting to a foreign antigen, and that is what makes you sick. And if the inflammation just keeps on perpetuating, or this response just keeps on perpetuating, then it becomes a chronic response. And so CIRS can mimic a lot of other chronic health conditions as well, such as chronic fatigue syndrome, fibromyalgia, and multiple sclerosis. And so there's a lot of overlap with these things, and sometimes it becomes hard to diagnose. But it really, if you can sum it up in one word, it's just inflammation, chronic inflammation.
So what happens to go wrong in the body that these patients' immune system recognises it as a threat, whereas a lot of us are still exposed to molds, still maybe come into contact with dinoflagellates. There are those people overseas that get infected with Lyme disease and recover. There's controversy in Australia, even though they've found a Borrelia, but people keep calling it Lyme, which I don't think it is, because we haven't got that species. Yeah. But we've certainly seem to have at least Borrelia here. There are those of us that come in contact with these threats, let's say, or noxious entities, but we don't react in the same way as people who get CIRS. What goes wrong?
Well, one of the important aspects here is, the genes that can actually play a huge role here. And so what they found is that those are gene mutations on, there's a subset of genes, and it's the HLA, DRB1, DQB1, DRB3, DRB4, and DRB5. And so they found that people with these kinds of gene mutations are more likely to develop this inappropriate immune response and be susceptible to getting sick from being exposed to mold or other infections. And so there's about 54 HLA-DR genes relevant and about 150 subtypes, which can make it very confusing. And it has gotten really very, very complicated. But we're using it now more as a kind of a guidepost. So what it indicates, it's more of a relative risk in a group of people that are more susceptible. So the more mutations you have, the bigger the risk and the more susceptible you are. And so these kinds of people, they will be more susceptible to develop CIRS after being exposed to a trigger such as mold. So again, just testing positive for an HLA gene mutation doesn't necessarily reflect what that HLA gene will do. So these genes are sort of like shaped like clefts, and then the antigens, when you are exposed to an antigen, will enter this cleft, where they are then sort of like recognized by the amino acids that's part of that gene. And some of the amino acids are permissive, which means it will allow the antigen to then enter the cleft and then leave without being recognized. And so this means that the antigen now has become like a stealth pathogen where no antibodies are actually made. So there's no protection from the acquired immune response. And then you get this constant activation of the innate immune response. And so susceptible people will just stay sick for longer, even after they are out of the environment, which has made them sick in the first place, whereas non-susceptible people will get better. And so the sick people's immune system, they are not tagging that organism and eliminating them. It's like it bypasses it just bypasses the immune system. The immune system is just not seeing it. And, we've got to remember that we are born with the HLA genes, but we are not born with CIRS. So there has to be an event that set this whole thing up. It could be something like Lyme, or it could be something like even mono, or some kind of a viral infection, or something that just has to initiate this process, but it's not necessarily the perpetuator of the process. And so I think gene involvement is a big one here. And I'm just talking about the HLA genes here, but, we could also include things like the glutathione genes, the SOD genes. If someone has just very poor susceptibility or a poor ability to clear toxins in general, all of these, I think, just add up. And I think this is just why some people, really struggle to get better, and why diseases are becoming more complex, and we have to really think beyond the square and how to help people get better, because it's not the usual things that can make the biggest difference anymore. There's now all these other nuances that comes into play.
I've got to say, when I first heard about CIRS, I was extremely skeptical, and the reason that I was skeptical was that I was thinking, how could it be a new disease? Are we just seeing the new flavour of the month diagnosis sort of thing? But then I started thinking, and I thought, hang on, we used to call tuberculosis consumption. There is no diagnosis in the 1800s for irritable bowel syndrome. So what were these people experiencing before, like back in the 60s, 70s, 80s, when we didn't have the diagnosis of CIRS? What were they termed as? Were they just lumped into chronic fatigue, or?
I guess that's what we could see it as that, and I tend to agree with you, Andrew. It's like it's not about giving something a new name, and we do tend to do that. I think this is why we have to be careful and not saying, well, you've got CIRS as a condition. It's recognizing that this is what the biochemistry is doing. It's stuck in a chronic inflammatory syndrome. And I tend to agree with you. I think a lot of those past illnesses could be classified in the same grouping, because we're just talking about biochemical processes here. So I am very careful not to try and make it as a disease, because that's what we tend to like to do, is just make up diseases. And
How did you first become interested in CIRS as a condition or a group of conditions to treat?
Yeah, well, it was actually at one of Ben Lynch's conferences. It was his ShyCon 2016, where I heard Dr. Keith Bernstein, I hope I said that correctly, but I heard him give a talk on CIRS relating to mold, biotoxins, and Lyme. And it was the first time I heard about it, and I was very, very, very interested. So I started researching it, and I found that so many people had these kinds of symptoms. And they failed to get the help that they needed, because it was still a relatively unknown subject here in Australia, and I think it still is. But it was already being talked a lot about in other advanced countries, and they were testing for these chronic infections, and they were testing for things like mold, which I think is actually a really big problem here in Australia, and especially in Queensland with the level of humidity we experience. So it wasn't really about a new disease, but it was interesting that the testing that was being done for it was so much more advanced than what I was used to here in Australia. So they were testing for organisms that we not usually test for. And they were, like I said, testing for mold biotoxins, which, it surprises me how many people, if I send them back home and they go look for it, they find huge amounts of mold.
Oh, yeah.
And yet we are not recognizing that as another source or another root cause of possible illness, I think it's going to change definitely in the next 5 years or so. And again, we have to be careful to not just see everything then as mold. But it is a very important another exposure that we need to be aware of, especially in humid climates such as the Queensland climate. So I just felt it was very underdiagnosed, very underappreciated, and it just made me look at things a little bit differently, especially the hormonal involvement. When you started looking at CIRS and how it influenced neuropeptides and the brain hormones and neurotransmitters and everything, it just really made sense why people get all this multitude of symptoms with all kinds of chronic inflammatory disorders. So for me, it was a huge connect the dots moment. It was just like, wow, here we see the immune system connecting with the brain, connecting with the hormones, connecting with just everything. And so I guess that's what sort of like tweaked my interest into it.
I've got to say, Nicole Bilsma shook my head around, basically, enlightening me to the prevalence of mould issues. I mean, it just absolutely stunned me. And then I started to think, I thought, we don't have a mould issue in our home. And then I thought, hang on. And then I see suddenly little bits around the house, and it's not a huge issue, but little bits of, soffit or part of the eaves that might have a bit of a mould issue on it, and I go, oh wow, it's mold will grow where it can, given a damp environment. It's just amazing. But again, what interests me is these people's response. So, how common is CIRS? Are we seeing an explosion of this? Are we looking for it, and therefore we're over-diagnosing it?
I think you could be onto something there. I don't have the statistics in front of me in terms of how common it is, but I think it's one of those things that we need to be careful that it becomes like chronic fatigue syndrome, where it becomes this huge label. And I think in that aspect, I think it's actually quite common. Just because of the amount of, when I see people come through my doors, and it could just be my client population, I see the strangest kinds of infections. Now, whether we are testing more for it, I think that is definitely a valid point. We are testing now for viruses and bacteria and parasites that we haven't tested for before. So now it's showing up. But I also think people are getting more answers. Like a lot of these people have been left high and dry by the medical system and even by other systems, in that no one knew what to do with them. So they would just end up going through life, with ill health and no one being able to help them. So that we just have more tools now with genetic testing and everything else that we can now pinpoint things. Are they getting better because of the testing? That's another argument we can have, because I know of people who've been on treatments for many, 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 many years for these kinds of conditions, and they don't really get any better. So I think it's such a, not talking about CIRS as a condition, but just all these infections and all these exposures, we still don't know what to do with a lot of these things. I think we're in the learning processes of treatment protocols. And I don't like to use the word protocols, because I don't believe in protocols, but I think we're still very much in the beginning stages of learning how we can get rid of, how do we get rid of viruses? How do we get rid of all of these things? So I think we are better at diagnosing and getting answers for people, but I don't think we're necessarily quite there yet in terms of the treatment. But we're understanding now the role that these organisms play more so in our general biochemistry. Because if you think about it, Andrew, in the past, if someone had, like a mental illness, schizophrenia or depression, that was what they had. But now we're connecting a lot of those mental symptoms to infections and to things like CIRS. We're starting to connect things that were just fobbed off as you have this disease, this disease, this disease, and now we're seeing it more as a global body dysfunction. So I think maybe we are over-diagnosing CIRS. I don't think it's more prevalent. I just think we're now starting to categorize these other diseases like schizophrenia or depression or hormonal disorders. We can now start to actually regroup them into something like CIRS, because we're understanding better that these are not isolated illnesses, that they are part of a bigger body response. So I think we're just really reclassifying things and sort of, putting things into new bags and putting new labels on them.
Yeah. To me, it seems to be kind of like that in the past we looked at alcoholism as a disorder, as the problem, whereas now we really look at alcoholism as a symptom of what's going on. Something is causing alcoholism to occur. That's the reason they're driven to drink, if you like. Is that sort of where you're heading with this, that we now have a classification, if you like, of what might of a group of things that might be going on, and we term it under one banner, but it's really a flag to say there's something going on here rather than what we should be falling down a diagnosis box, as you say. Yeah.
That's correct. We could say that we're seeing CIRS now as more of a recognition of root cause, because 50 years or so ago, you can take the microbiome as a good example. How long have we said that gut bacteria has an influence on the brain, and the medical community just didn't want to accept that. But now it's the new big thing, isn't it? Everyone's now recognizing the role of the gut microbiome in all these illnesses. And it's the same with CIRS. It's really just a banner to say, hey, all of these things that you classify as diseases has a root cause, and the root cause is going to be some kind of a bug, some kind of a mold, some kind of a toxin. And this is the way the body responds to it in this inflammatory process. And if you don't remove the exposure, the inflammation will just keep on going and creating these biochemical dysfunctions. So I think it's just really a recognition that there are root causes that we haven't seen before, because we didn't recognize that a root cause can actually cause these kinds of responses. So I think it's that same thing. We're just really starting to appreciate the environmental influences on things that were commonly just labeled as a disease. And now we're seeing that, no, it doesn't work like that. There are always some kind of an exposure or a root cause that we need to look at. So that's, I guess, what you could see CIRS as, is just a recognition of that.
Yeah. So, okay, let's talk about the key signs and symptoms of somebody with CIRS. What sort of things go on? I'm imagining all sorts of issues, because it's a general sort of thing which could present in any number of ways. Is that correct? Or
you are very correct, Andrew. So, it's going to sound like the same old when I say the symptoms, because you are right. It is a very a globalized kind of signs and symptoms. So, you'll get things like your chronic fatigue with a lot of cognitive issues or brain dysfunction, a lot of executive cognitive function problems, because a lot of the brain areas gets affected with CIRS. There can be respiratory issues, especially where mold is maybe more involved. There can be GIT issues. They can have diarrhea and constipation, muscular pain, fibromyalgia, mood swings, night sweats, excessive thirst and urination, hormonal dysregulation, which is very, very commonly seen. And a very interesting symptom that I do think is a little bit unique is a static shock sensitivity. So, which I thought was quite interesting. So that is a little bit of a unique symptom when it comes to CIRS. But yeah, definitely a lot of globalized symptoms that you can put in the bag of chronic fatigue syndrome and a whole bunch of other ones. So those are the kinds of signs and symptoms. And I guess especially in people where they're not finding any resolution with normal treatments, that's sort of like where you have to start looking for something more deeper or sinister going on that's perpetuating that inflammation.
With regards to the static shock sensitivity, that one interests me. Is that because they're sympathetically dominant and their alert reaction is heightened? Well,
that is actually an interesting one, because when I sort of like researched that, it seems to be to do with the ADH, or the antidiuretic hormone, which is one of the neuropeptides that gets dysregulated with something like CIRS. So the antidiuretic hormone is produced by the hypothalamus, and it induces the kidneys to conserve water. And so if you have low alpha melanocyte stimulating hormone, which is another neuropeptide involved in CIRS, then that will sort of like lead to low antidiuretic hormone. And so if the antidiuretic hormone levels are low, then water is not actually being reabsorbed by the kidneys. And so this is why people with CIRS will sort of like feel the need to urinate a lot more. And so you become more thirsty, you become dehydrated, and then it creates sort of like osmolality changes and can make inflammation worse and sort of result in low blood pressure. But it's actually apparently this change in osmolality, and also then the sort of like changes in the delivery of oxygen and nutrients into and out of the cells that can seem to make you more susceptible to shocks of static electricity. I may not have explained it as well as I should have, but it seems to be more something to do in that kind of dysregulation system. And yes, that's the hypothalamus control. So for sure, we could definitely tie the sympathetic nervous system in there as well.
So I'm imagining, you said rabbit holes at the beginning and rabbit holes within the rabbit holes. I'm thinking about a big one here. How do we test patients for it?
Okay, so there is a lot of rabbit holes. So testing, this is, I guess, where you can get sort of like differences of opinion. There's a lot of kinds of testing that you can look for. If you look at the general CIRS testing panels, you'll see that a lot of times they'll test for things like your MMP9, your C3A, C4A, TGF-beta1, MSH, VIP. That's sort of like the general panels that you will see on a blood test for something like CIRS. And these are all just markers of various forms of immune activation and inflammation. They are very useful to measure to see if there is that chronic inflammatory response going on, which is way beyond, our average CRP ESR testing that we have on the general blood panels. And there are also really good markers to measure if your treatment is working, because you can just measure these markers from time to time, and if they come down, your treatment works. If not, well, then you need to look for something else. But there are, some practitioners will do a lot of the gene testing, so all those HLA, DRB genes that I was talking about. I personally feel that, with my population, they don't have a lot of money, so I have to be very careful with what kind of testing I do. So the gene testing is not the first test that I would do, because in my opinion, I don't really care what genes you've got. I'm interested in what's causing this inflammatory response. So I would tend to look more for the root sources. And so some of the testing that you can do is you can actually get tested for all these mold biotoxins and aflatoxins. But a very cheap test that you can do, Andrew, is the VCS test, or the Visual Contrast Sensitivity test, which there's quite a few websites where you can get this done. The Surviving Mold website is one of them, which is Dr. Richie Schumacher's website, as I understand. And it costs you like $10 or $15. It's an online test, and even though the online test is not as good as the actual in-clinic test, it is still a very widely available, easy to do test, and it literally takes you maybe 10 minutes or so. It's a visual contrast test you do online, and from that you can sort of get like a pass or a fail in terms of whether there could be a CIRS kind of response going on in the body, because it measures the hyper or the hypoperfusion in the capillaries of the eye, which is very highly affected when there's a chronic inflammatory response going on. And so it's sort of like an easy test you can do that if you fail it, you can say, well, okay, there's something going on here. I think I may need to investigate this further, and then you can go on to doing more expensive kinds of testing.
Gotcha.
But there's also other testing, there's neuroquant testing, which is more of a brain imaging kind of testing. There's really a lot of ways you can go about it. I think this is where clinician skill comes at hand, because you still have to think, what do I think is the trigger here for this person? Is it do I suspect more of a mold trigger? Do I suspect more of a Lyme trigger? Do I suspect more of an environmental chemical trigger? Because that can also direct your testing as well. And what are you going to test for here? But the general markers that I gave you there in the beginning are sort of like where a lot of clinicians start as we're dealing with the CIRS. Now let's find the trigger for this.
Gotcha. So I just looked up, so vcstest.com. Is that the correct test site? Yeah?
Well, that's one of them, yes. Or you can go to Surviving Mold. I think there's a few websites that provide this test. So Surviving Mold is another one where they have the test available there as well.
That's awesome, because I think, inexpensive testing measures are sorely needed. They are dire. Yeah, we don't have very many of them, and particularly when, as you say, these people are the sickest of the most cohorts that you'll get most group of patients that you'll get. So they really need every ounce of help they can for as little expense as they can. That's
Oh, definitely. Yep.
So approaching treatment now, and again, here's another rabbit hole. How do you treat stuff? I guess we've got to get away from treating CIRS as a label, as a box, as I said, and rather treat their particular issues. Is that how you do it? You sort of personalise their treatment program?
Yeah, that's how I would certainly do it. I mean, again, you'll get lots of differences of opinions here because people like protocols, and so there are certain protocols in treatment. The number one thing you have to do, no matter who you are or how you approach this, is you have to remove the exposure.
Yeah.
So, there's no point in getting into specific treatments, whether it's antibiotics or herbs or what have you, if you haven't actually found the source and stopped the exposure. Because everything will just be useless until you do that. Toxins in must be less than toxins out. And so this means you have to identify the source and remove it or clean it. You have to either then remove yourself from the environment completely if you cannot clean it, or you have to treat the infection if it is an infection-driven process. So that, to me, is the absolute number one, is identify and remove if you can.
Yeah.
Because if you only treat the downstream effects, if you go and test, and I think this is where the issue comes in, is we see, this person's hormones are out, so let's treat their hormones. Or, serotonin is low. And if you just treat those downstream effects and not the root cause, then they'll just never get better. It becomes a revolving door in and out of the clinician's, clinic. So that is definitely the number one thing. The number two thing for me, a big one, is fix the leaky gut. And this sounds like a broken record, but my goodness, I think that is such an important aspect. And I don't want to just become the leaky gut kind of person. And I'm not saying everyone has that, but I think it's fair enough to say that I think that is an important issue for the majority of people out there, given our lifestyle. So if you have a leaky gut, then your treatments are also going to be ineffective. So this is all just about making the treatment effective. You have to make sure that their gut is supported. That is a big thing, especially if you go back to the mold biotoxin example, all those HLA genes, they are, the celiac genes are involved in there. And so a lot of these people will have a tendency to more of a leaky gut kind of, phenotype. The third thing for me that's very important is you have to make sure that their detoxification systems are working. Again, you can treat them with all these things, but if they're not detoxing, you're just going to make them sick. You're going to make them worse. They're not going to get rid of these things, because one of the main reasons why people stay sick who have been exposed is because they're not detoxing well in the first place. So you can't go ahead with treatments if they're not detoxing. You have to make sure their bowels are working. You have to make sure that the kidneys are supported and the liver is supported. It's all those boring things that we don't, we think, well, we need to find some fancy treatments. You have to have the foundations right. It's always about the foundation. So, those are sort of like the key things I would start off with. Once that's in place, then I like to use binders. So binders is some of the things that I think is a very important thing to get in early on. Now, if you're following sort of more the Dr. Schumacher's protocol, then cholestyramine or Welchol will be the kind of binders that would be used. But, not all of us have that access. So you could use other binders as well, more your natural binders like your zeolites, your charcoals, your bamboo, your modified citrospectin. But I will emphasize there hasn't been a lot of research done on this. I think this is where we're lacking a little bit, and I think we really need to explore more in the future, is we have not really done much research in the natural treatment or the alternative treatments for these kinds of conditions. So there's not really data on this. Like, I can't say that this is going to work or that's going to work. It's going to be very much a case-by-case process where you just have to try things and see if the person gets better or not. But it would be so amazing if you can start getting more clinical data on this kind of stuff to see what actually works and what doesn't work. Because currently we have data on things like the cholestyramine, but we don't have data on any other kinds of binders. But I think that is a very, very important part in the treatment protocol, as well as having binders on board, so that as you treat the person, that you can actually bind these toxins and move them out, and they don't get reabsorbed back into the system and just keep this inflammatory process going on. So that sort of like is definitely the core of treatment. Then there's lots of other spin-offs depending on which protocol you use. They use a lot of VIP treatments and things like that in the Schumacher protocol. I think we still can learn more here about which way to treat people. So I don't want to, say too much about protocols, because I don't want to get practitioners stuck in that mindset. I think if we make sure the foundations are correct, and then we just have to sort of like look at what is the source and treat it the source, because you will treat the person differently depending on whether it's a mold exposure, or depending whether it's a co-infection or a viral exposure or a toxin exposure. Your treatment will differ there, but the core foundations will always stay the same. And so that will be my approach to treatment. And then I will just sort of individualize from there on, depending on what I think is the key issue for them.
And I'd just like to remind our listeners that cholestyramine is a drug and therefore must be appropriately monitored by a medical professional, and it's not without risks. It can have issues with thyroid hormone absorption, and there's a metabolic issue with salt. I think it might be chloride. Another major issue is constipation. What about any red flags that we need to be aware of? I guess the one that's in my, uppermost in my mind when you spoke about urination was diabetes. How do you then tease apart red flags that you need to go, oh, no, hands off, I need you to get this checked out first?
Yeah, okay. So there's a couple of check boxes that, have to be ticked when you sort of you want to suspect that this is more of a CIRS kind of pattern rather than something like diabetes. And so the tick boxes are when you find someone with multiple unexplained or non-responsive symptoms. In other words, you do the normal thing with whatever you think is going on with that person, but they're not responding. So it's those really hard cases where you're just like, man, this is just not going the way that I thought it was going to go. And you put your hands up and you say, I'm a little bit lost here. So it's those kinds of cases you really need to look at. You need to look at past or current history of exposure to damp, moldy, or water-damaged buildings or tick bites or anything like that. Usually they like to include that there has to be at least one HLA-CIRS susceptible genotype in there. I don't know if I would put much emphasis on that, but that is one of the criteria that they would sort of put a red flag on. And also where the person shows a pattern of an innate immune inflammatory response. Now, something that to be aware of, Andrew, which I thought was really, really interesting, and this is I don't think the paper is published yet, and it may be published a little bit in the next few months. But I think it's quite relevant to just mention this because of the testing that we're doing, and we need to understand the pitfalls with testing as we are doing it currently. Dr. Dietrich Klinghardt and Dr. Marco Ruggiero, I hope I've pronounced their names correctly, but I have huge respect for them because what they've done is they've actually developed like a unique way of testing for chronic infections. Because one of the things that we've found is that a lot of these chronic infections, co-infections, such as Borrelia and such as Lyme, but I think many others as well, they can sort of like set up compartments in the body and they can hide really well. So they're not necessarily in the blood. They're usually sitting in the tissues and sitting in the cells. But what are we testing for? We're testing for blood. I cannot tell you how many tests I have seen for Lyme that it comes back. It's not really positive. It's not really negative. It's sitting there somewhere, so they put it as a fail. And what we need to understand is that you can, if you have chronic Lyme, if it's acute, yes, you'll pick it up in the blood. But if it's chronic infections, they could sit in the right hippocampus of the brain, but not necessarily in the entire brain. Or they can sit in the brainstem and not in the liver. You don't know where these infections are sitting. They can be in biofilm. They can be inside cells because they don't really move around a lot. So what they found is that if you want to test for a chronic infection, you have to coax them out. because we're not really doing tissue samples, we're not doing biopsies, we're doing blood testing. And so Dr. Klinghardt and Dr. Ruggiero, they've developed like a unique way of testing where they will actually use ultrasound treatments in the brain, in the thymus, in the spleen, the vagus nerve, and the brainstem. And in this way, they're driving the microbes out of these areas. And then some of these microbes will then spill into the bloodstream, and then it can be tested for in blood, or there's now, I think there's a new test available now where they actually collect the urine and they do PCR testing on the urine. And then that's where they will test for or look for the whole strands of DNA and microbes in the urine. So they are actually finding now where tests previously came up negative, now they're coming back positive. And so I did want to emphasize that because I think we get fixated on testing and we're like, oh, well, the test was negative, so that's it. And we need to understand the limitations of tests and what are we actually testing for. Because I still, you cannot treat the test. You have to treat the person. You have to look at their case history. If they're chronically inflamed and you know that there is something going on, but the tests come back negative, and you just believe in the test and don't treat the person because the test says there's nothing there, you have to understand the limitations of those tests. So I just thought that is a really important thing to point out because as practitioners, we can get really stuck on these things because it is easy. We want the answers given to us, but sometimes the answers are not there, and you have to understand the limitations of that. So I just thought I'd point that out as another kind of a risk factor in getting the diagnosis wrong just because you rely too much on what a test is telling you. So I just thought I'd put that one out there as well.
Where can people get further information and resources, education on this topic? Because it seems to be very involved. Still not without some areas that need to be cleared up, but I think there's some people working on it diligently. Yeah,
the research just keeps on coming out, and there's some very exciting things in the pipeline which I'm busy investigating as well. But if they want to go and, I'm assuming that a lot of the practitioners here will be very new at this or fairly new at this, and they just want to get sort of like some kind of idea of what to look for and treatments. There's a couple of resources you can go to. One of there was just very recently a talk done in the UK by the Academy of Nutritional Medicine, which was in the whole CIRS kind of syndrome. And there was a few very, very prominent speakers there, and they can download the notes from the website. It's www.aonm.org. If they go there, there were some brilliant speakers, Dr. Jess Armine from Bioindividualized Medicine, Dr. Dietrich Klinghardt, Dr. Armin Schwarzbach. They were all speakers at this conference, and they notes you can just download them and read through them. And then obviously Dr. Richie Schumacher's website, survivingmold.com, is another really good resource as well. Dr. Keith Bernstein, which is an MD from Park Ridge Multi-Med Clinic. I don't have his website, but that's definitely another person that you could look into and follow up on. These are all people I really respect in the community of CIRS, and they all have a slightly different take on it. Some of them will focus more on infection, some of them will focus more on mold or other things. But these are great resources to go and have a look at if you want to sort of learn more about it.
So we'll definitely put aonn.org up on the FX Medicine website for our listeners, and some other resources there as well, so that people can learn more about this very complex issue. Elizma, any further points that we need to sort of add in just before we wrap up?
Andrew, I will just mention the most important thing for me that I would like to leave practitioners with is, and I have said that before, always treat the patient, don't treat the test.
Yes.
You have to really take a very, very good case history, and you have to do a timeline with them. Timelines are so important. You have to see where was the point when things started changing for them, because that's where your answer is going to be. So, it could have been a viral infection they had as a teenager. It could have been an exposure to a toxin where they were working at, or, it could be, like I said, a tick bite, or when they moved into a new home, or an older style home where they could be exposed to mold, the timelines are so important, because that's going to give you your answer in where your next test will lie. Instead of just doing a whole barrage of testing, do a timeline, see where you think where the first exposure happened, and that will direct you to your next step, which would be testing and finding the root cause.
Elizma Lambert, thank you so much for taking us through those rabbit holes within rabbit holes, which is CIRS, and really teasing apart the relevant points for patients to get better. I love what you said. Always treat the patient, not the test. Thank you so much for joining us on FX Medicine today.
Oh, it was a pleasure. Thank you so much, Andrew.
This is FX Medicine. I'm Andrew Whitfield Cook. Don't forget to visit fxmedicine.com.au for today's show notes, extra research and other resources.